Welcome to this Peer Voice activity. To access the entire activity, including supported material, go to www.peervoice.com/fjs. This activity is supported by an unrestricted educational grant from Bayer Healthcare Pharmaceuticals Incorporated. Bayer has had no involvement in the selection of the speakers, the development of the activity, the agenda, or the materials.
Good day, everyone, and welcome to the webinar series entitled Reevaluating the Role of Radiopharmaceuticals in the Management of Metastatic Castration-Resistant Prostate Cancer, or mCRPC, and how should recent data inform individualized treatment. So, I'm Professor Fred Sad from the University of Montreal, and it's a pleasure to be accompanied by my colleague and friend, Pedro Barata, who's Associate Professor of Medicine at Case Western University and senior attending and a co-lead of the GU disease site. We have a limited amount of time, so we won't spend too much time on this and get straight to the importance of this first of a three-part webinar series that reevaluates the role of radiopharmaceuticals in the management of mCRPC and how recent data should impact our treatment decisions. So today we'll be discussing the novel data surrounding radiopharmaceuticals, both Dr. Barata and myself. Obviously, in the short amount of time, we can't go into the details of all that has occurred since 2004, when docetaxel was the first to show that we can actually improve survival of this most advanced state of the disease. And since then, it's been wonderful to see all the additional treatment options that have come about, all with advantages in overall survival, or at the very least, very significant radiographic progression survival endpoints. And what's highlighted are two radiopharmaceuticals, radium-223, that's already over 10 years ago was reported, now almost 15 years ago in 2013, and more recently lutetium PSMA-617, which reported in 2022 and got FDA approval very soon after. So can early use of combination treatment with radiopharmaceuticals improve clinical outcome in mCRPC? And this is where we've been struggling for almost ever since we've had treatment for mCRPC, is that we've been using sequential treatment rather than combination, as in almost every other solid tumor, and this is where we have to work. And so it was wonderful that this trial, a randomized trial, cooperative group trial, led by EORTC, looked at patients getting enzalutamide for mCRPC with or without radium-223. And the study had a primary endpoint of radiographic progression-free survival, which was significantly improved by adding radium in the early setting of mCRPC in combination with enzalutamide. So compared to a life-prolonging therapy of enzalutamide, there was a 30% reduction in the risk of radiographic progression, which was very statistically significant in this study. And more recently, and recently published and presented, was that the final overall survival over and above the rPFS actually turned out to be statistically significantly in favor of combining radium to enzalutamide compared to enzalutamide alone, which is a worldwide standard of care, with about a almost 6-month improvement in overall survival, almost unheard of in this state of the disease. So this is, I think, extremely reassuring for patients that we can now think of combination. And when we looked at subgroups, every subgroup really benefited from the addition of radium to enzalutamide. Everything was on the left side of the forest plot, except the patients over 75, which may not have as much benefit as all the others, regardless of performance status, whether or not they had been exposed to chemotherapy, and whether or not they had extensive bone metastases or a lesser burden of bone metastases. So I think quite encouraging data. And in terms of adverse events added to enzalutamide alone, this was a very well-tolerated treatment, nothing close to what we see when we combine with chemotherapy, and overall very reasonable adverse event profiles, very little in terms of adverse events that impacted the quality of life of these patients. And more recently, we're starting to see data of other combinations with radium-223, looking at olaparib in combination with radium-223 compared to radium alone. And here we're already starting to see some inklings of maybe a favorable outcome in these patients. Relatively small study, but still in favor of adding radium to olaparib compared to getting radium alone in terms of rPFS. And same thing in terms of whether or not they had prior docetaxel or not. Obviously, the patients with no prior docetaxel seem to be getting even more advantage, so earlier appears to be better, but we're still seeing a difference even in patients with prior docetaxel. And another study, looking at whether or not they had extensive bone metastatic disease, less than 20 bone mets seem to be getting more benefit. So the bottom line is the take-home message: earlier appears to be better than waiting too long in these patients that are metastatic castration-resistant. And I think this data needs to be confirmed in a larger study, but looking in the right direction. And again, adding olaparib to radium-223 appeared to be well tolerated in general. Yes, slightly more grade 3 events, especially in terms of anemia, and this is known adverse event of PARP inhibitors. So I'll hand it over now to my colleague, Dr. Barada, to talk about lutetium.
Thank you so much, Dr. Sad, and thank you all for joining us for this one of several webinars out of this series. So just moving on, thinking a little bit about ENZA-P, this randomized phase 2 proof of concept, asking the question if there's a benefit of adding lutetium PSMA on backbone enzalutamide, which is a standard of care for mCRPC, as we know. The primary endpoint on this trial was PSA progression-free survival, and you're looking at the primary endpoint, which was met. So you get the medians there, 13 months with a combination of enzalutamide versus 7.8 months for enzalutamide. So again, positive study here, proof of concept, if you will. There's a few other endpoints of interest, yet immature. You see the survival signal here, favoring also the combination of enzalutamide with lutetium, 34 months, so close to 3-year mark there, compared to about 2 years or so, a little bit over 2 years for the enzalutamide monotherapy arm. And when we look at the quality of life perspective or angle, which is important, keep in mind on these graphs, you want to see the lines lower, not upper, because the score means more symptom reported by patients. So if anything, you'd say, there's no detriment in the CIF or in the experiencing the combination on the patients on the trial. If anything, looks perhaps better. So no detriment seen from a fatigue perspective and as well as from the pain perspective here as well. Another consideration is, of course, treatment-related adverse events. You have a big list here, several grades. I would probably highlight a little bit of the cytopenias or even the fatigue, some nausea that we can consider. And the way to think of this, or the way I digest this in clinical practice is, what do I expect to see in an RPI like enzalutamide? And then what do I expect to see with radioligand therapy like lutetium PSMA? So no new safety signals here. Moving on, so lutetium has been tested with different therapies, right? So we've shown you data for enzalutamide combo. Here you're seeing phase 1 data in the combination of PARP. Why? Well, it appears to be this hypothesis that maybe a therapy that, DNA repair gene defect that takes advantage from it, maybe we leverage that mechanism of action by at the DNA level of the tumor cells, if you will, by combining olaparib with lutetium PSMA. Different cohorts, I know it's complicated, you have different cohorts here, but it's provocative and promising, I think, to see tumor control, median tumor control over a year, on both cohorts here for the LuPARP study as well. So we look at survival significantly immature, take it with caution. Yet you can see the vast majority of patients were alive at 1 year mark, and in the different cohorts, you have the median survival approaching the 3 year mark for one of them, and not reached on the other. Again, immature data, but nonetheless aligned with the efficacy signal that we've seen. One more heavy data slide. You have different cohorts, different treatment-related adverse events. I would say for the most part, toxicity was manageable. I will highlight the myelosuppression as something to take into consideration, and I think it's reflected here from the different components, whether you look at anemia, et cetera, cytopenia in general, right? So keep that in mind, is something we'll have to consider. So with that said, maybe I'll ask Dr. Sad, does any of these data, that said, is impacting the way you're managing patients today with mCRPC, perhaps thinking of keeping patients on RPI or not? What are your thoughts?
Well, if definitely, I mean, we've always wanted in the first line setting, and this is really the biggest opportunity we have in the first line mCRPC setting. And piece 3 really addressed the question, can we do better than an ARPI alone in the first line setting in mCRPC? And, adding radium-223 that we use later down the road earlier, I think now we have really high level evidence that we can do better than enzalutamide, both in terms of delaying progression, but especially important is that the overall survival met its endpoint with a very small study. So I think really important, and I think highlights also the importance that you get all 6 cycles when we give it a little bit earlier than waiting post-ARPI, post-chemotherapy. So definitely it has changed my practice, and depending on jurisdictions, being able to do this can vary, but if there's an opportunity, I think the experience has been very, very good. I don't know what you think.
Yeah, I agree with you. I got back radium-223 in my practice, something that for the last several years I wasn't using as much because I was trying to lack the exact space. But once the piece 3 data was presented, it gave me a lot of lessons. Definitely trying to leverage on that front line NCRPC, particularly RPI naive patients who get there progressing on ADT. Definitely, I am considering that combination. When I'm thinking of lutetium, we are allowed to do lutetium pre-chemo in the CRPC space. Many times I do consider keeping the RPI they're on or adding an RPI, if you will. Most of the patients in the US, when we treat them, they are RPI exposed or progressors. So that's always a debate: should I keep them on or not? And data like the one I presented, makes me think that sometimes when they're on, and I think it's safe to do it, I do consider it as well.
I think we both agree that effective therapies brought earlier in the disease state seem to have more effect, more benefit, used, especially if they can be safe. So, and this is one of the comments that were brought up, is that in the management, these patients will not be cured. mCRPC is an incurable disease. What we want to do is keep these patients alive and well for as long as possible. And the biggest impact is always in the first line. So being able to introduce effective therapies as early as possible when patients are better able to tolerate it. And, many patients ask us, can we delay chemotherapy? Can I avoid chemotherapy? And I think that is our challenge now. Even though I love chemotherapy and I use a lot of it, I think, unfortunately, many patients will not accept chemotherapy. And so we have to do the best we can as early as possible. I don't know if you have any other thoughts on what you would do after a radiopharmaceutical. Assuming that we've got access and we can do, the sequence of ARPI with a radiopharmaceutical upfront or in sequence, what would be your approach after? Is it always chemotherapy, or do you have other ways of treating patients?
Yeah, that's a great question. And I think we'll have a slide on the NCCN guidelines kind of showing us that. So we are facing the case because, we got an uptake here. They use a radioligand therapy, pre-chemotherapy, when taxane is used in the CRPC setting. As you know, the minority of patients are not being exposed to docetaxel in the hormone-sensitive space. There's been a minority of them. So we have those kind of PSMA4 therapy patients, or enza-radium treated patients and what to do next. On the latter group, I think, data like RALU, this post-marketing data showing this, that we don't lose activity from thinking of radioligand therapy after progressing on radium-223. So I feel very comfortable sequencing radium-223 and then something like lutetium PSMA when I don't have a clinical trial available. For patients who were treated with lutetium and RPI, I would say probably the default plan will be chemotherapy. Some patients that I haven't been, for some reason, don't have genetic testing, I would think about target therapy, although I would argue if I have a BRCA patient, I probably would prioritize a PARP before I probably would do RLT. But there have been cases where we find that out later time. They come to us already treated with lutetium, and then we find out that they have a genomic alteration that I can act on, if you will. And so that has been our practice. And again, excluding clinical trials, which we've been heavily, enrolling on. But I will say patients who come to us treated previously with radium-223 in general does not inhibiting us from considering all options available at that time.
Yeah, and I think that's what I wanted to get across as a take-home message is the importance of trying to personalize and as much as possible and understanding what we're treating. And if necessary, go to a biopsy if you think they're going towards a neuroendocrine. But just to highlight that the NCCN now includes radium plus enzalutamide in patients with bone metastases that are in the pre-ARPI setting. So they've already made it to the guidelines. So this is now considered an option that we can offer patients. And same thing for ESMO, where ESMO also has included enzalutamide and radium as a therapeutic option in patients that have had no prior ARPI and are just starting the ARPI. I think the question is in patients ARPI exposed, especially abiraterone, those patients were allowed to be in piece 3, and we saw a signal that those patients also benefited. Unfortunately, the numbers were relatively small, but it would make biological sense to probably try a combination in patients who are on abiraterone in the hormone-sensitive setting, especially patients who had prior chemotherapy. So this was very short, very quick, and I hope it was useful to review things that we don't often talk about. So thank you very much to everyone, and thank you to my colleague, Dr. Barata, for taking the time to do this with me.
Thank you very much for doing this, and thank you for your attention.
Good day, and welcome everyone to this webinar series entitled Reevaluating the Role of Radiopharmaceuticals in the Management of mCRPC, and How Should Recent Data Inform Individualized Treatment. So I'm pleased to serve as the moderator. I'm Fred Sad, Professor and Chairman of Surgery at the University of Montreal, and I'm in the company of Mikael Lackstrom, who is a patient advocate, but actually is well placed to talk about the subject of today because he is a patient himself who has been living with prostate cancer. And so we welcome Mikael. And so today is the second of a 3-part webinar that will be focusing on the patient experience and priorities from care. And I think this is something that unfortunately is not discussed enough as healthcare professionals, putting ourselves in the patient's position, living with prostate cancer, and we'll be focusing on their experience and how to better understand the realities. So when we're considering treatment selection in mCRPC, there are several aspects that have to be considered. There are treatment-specific aspects, the prior treatment and sequencing. Obviously, the next line really depends on what patients have had prior to this state of the disease, considering the efficacy and tolerability of therapy. Then there are disease-specific conditions, obviously the burden of disease, where the disease sits, whether patients are symptomatic or asymptomatic, can sometimes play into the urgency of making a decision, considering tumor markers, whether PSA, PSMA, and obviously now genomic markers have a huge role, whether they're HRR mutated, especially with BRCA mutations, and there are more and more of these genomic markers that are coming along, whether it's PTEN deficiency or others. And then what we want to focus on is patient-specific criterias. How fit is the patient? Consideration of comorbidities, how they responded to previous treatments, and especially important, patient goals for treatments. And all these considerations should be reviewed to define the optimal treatment sequence for individual patients at each stage of the disease trajectory. So let's quickly go over a case of a 68-year-old man who lives independently and values greatly staying active. He was initially diagnosed with mHSPC, so hormone-sensitive prostate cancer that was metastatic with bone mets 4 years ago, treated with ADT and showed a good response. He unfortunately progressed as expected to mCRPC after 2 years of treatment with 5 bone lesions, no visceral metastases, mild bone pain, and genomic testing showed that he was HR negative, had no MSI high that was detected. So now let's turn it over to Mikael and get the patient's perspective on where he is.
Of course, after the initial shock when you get the diagnosis, then you start thinking. And then it's, of course, very important to know the different alternatives and what they are meaning. And it's 5 years ago now for me, a little over 5 years ago, I got the diagnosis, and everything went fine, even if I have several bone metastases from skull to kneecaps. So the prioritizations in the start were quite were of course to be kept alive, and it's moving a little over time, these priorities, because you also the longer you go on, the more also the quality of life is important. So it changes a little over time.
Okay, so it started with living as long as possible, and then after some time, what I'm understanding is quality of life starts taking a little bit more place in your decision making.
Yes, but that is, of course, also an age question, because if you are 43 when you get it, then you have both very, very much. If you are 67, as I was, then the perspective is different.
And what kind of support do you think, well, you as a patient and others need at this stage to help in their decision?
Of course, knowledge is always the trump, but it has to be a knowledge that you understand, and that's very, very different with different patients. So I think a solid knowledge about alternatives, what they are, also the side effects and so on with them, so you can make an educated choice.
Right. Yeah. So you want to have as much information to make the most appropriate choice for yourself. And in your experience, if you ask questions, having a doctor or a healthcare professional taking the time to listen and try to address your questions, is that of importance, or getting the information and letting you make the decision? Help me to understand if I.
Yeah, of course, if a patient is overflown with a very very long explanation of facts, then you can't take them in, so to speak. So you have to get them in a form that is suitable for you as an individual. So yeah,
I think that's very important, because sometimes I get patients coming for a second opinion telling me that they weren't able to ask questions. The physician was not really willing to take the time to answer, was basically leaving them on their own. So, if we go to the focus here, because we want to discuss radiopharmaceuticals as a treatment option what concerns or questions does a patient typically have, including yourself?
It is, of course, the radioactivity is some kind of ghost. So
Mhm.
that is, I think it will be a concern for many patients. I
The
may
myth, the myth. Yeah.
the myth about radioactivity,
Yes. Yes. Yes.
especially the new isotopes that are working with quite a low total radiation amount. So, and also all the new methods are keeping the dosage very low. So
Yes. Yes. Yes.
when you compare with old methods,
Yeah. No, I've had patients saying, is this going to cause cancer, right? Because historically, exposure to radiation causes cancer. So
yeah,
these are questions that are fair questions, and we can't, just ignore them. These are patient worries, and having, you have had the experience of receiving both lutetium and radium-223. How would you describe your treatment experience?
uh, for me, actually the both, especially the radium, didn't cause me any notable side effects at all. So in my case, the hormonal treatment was, of course, the most caused a lot of more side effects. But I'm just one case, of course. So, but I didn't experience any specific side effects of these treatments. And I had radium for half a year. So
So you had all 6 cycles of radium,
yeah,
and more recently you've had the experience of getting lutetium
no,
PSMA.
no, it was in the very start of my
Oh, you
treatment.
got okay. So you got lutetium to start. So a little bit unique your situation.
Yeah, it
With
was.
lutetium, yes, yes.
Yeah, the reason was to take down the PSA from 60 to under 1,
Okay, that's very
because
interesting. Yes.
to take it down, but also the hormonal treatment. So I got the double treatment there,
Yeah.
and then the external radiation
So
and
you were ahead of the
brachytherapy.
game. You were ahead of the game because now we're doing clinical trials early lutetium. So you were ahead of the game several
Yeah.
years ago. That's very interesting. So, yes, and you're not alone. ADT does cause a lot of side effects, and is a big complaint of patients. Um, so thank you very, very much for sharing that. So this patient, 68 years old, received radium-223 plus enzalutamide, having progressed after ADT alone. And he completed all 6 cycles and had initial disease control achieved, and then progressed after 2 years with 4 small asymptomatic bone lesions, 2 lung nodules, HRR negative, TMB high, not detected in this patient. So in the first line mCRPC setting, he had a good response with enzalutamide and radium-223. So, after failing this kind of therapy, and now you're now in your second line, or your mCRPC, how do your priorities shift between your earlier and now more recent journey as you progress?
It was going from long life to quality of life, if you put it very simple. That's of course also an age question, because the older you get, the more you validate the quality of life.
Okay, well, yeah, and I share that experience with my own patients, that what is the priority at the beginning might change over time. And for patients who are hesitant to go further, what kind of information or support do you think these patients require to help them make the decision of whether to continue or to stop and accept palliative care?
I think others to have also a patient experience information, other patients, how they have had their experience. So reading good books in the matter and so on.
Okay. Yeah, that's very interesting. So, you serve as an advocate, and I think you have helped other patients, and I totally agree. I mean, having other patients that have gone through these new treatments is extremely helpful. We found, and we call these, patients that are partners, patient partners, to help navigate and demystify some of these treatments, whether it's chemotherapy, radioligand therapy. Mm-hmm.
Yeah. Yes.
Yeah, and what do you think the role of caregivers should play in these discussions?
Sorry, what?
Caregivers or healthcare professionals. I mean,
Yeah.
or your partners, or your family. What kind of role should they play in these?
Yeah, that is also, of course, a very important thing, and also all level of the caregivers are important in the scope of the total scope of it. So,
Right. Yeah, absolutely.
but a good home base is, of course, very important, even if that is not given for everybody. So,
Yeah. Yeah, I'm always a little bit
then you have to
concerned.
complete with other supporting things.
Yeah, that's what I found. I mean, whether it's a spouse, a child, or somebody else in the family or in the friends, when patients come completely alone, I'm always a little bit concerned. I
Yeah.
find that they need to have some kind of support, uh, and some kind of reason to want to continue to fight. So this
Yeah.
is extremely important, and helps them to understand, because sometimes we can be overwhelmed, and having somebody else in the room helps to reassure that everything was understood. Yeah,
Indeed.
so
I think these patient support groups are very important also, where patients discuss between themselves. So,
so unfortunately we're running out of time. This is
yeah.
extremely interesting. I mean, I've really enjoyed this discussion, and just maybe to summarize the strategies to engage patients effectively, present options clearly, the benefits, the risks, avoid assuming patients that the patient priorities. As much as possible, involve caregivers whenever it's relevant. Use clear, plain language, address uncertainties, make sure the patient understands what's being discussed, and importantly, the expectations have to be realistic. I think, Mikael, you did a great job to make sure that we as healthcare professionals realize this is what's important for patients, and we've progressed through the webinar. Thank you again, Mikael, for
Thank you.
to share your experience.
Thank you, Dr. Fred, and excellently put in one package this complex question. Thank you.
Thank you. Thank you, everyone, for joining this webinar on behalf of Pure Voice. Reevaluating the role of radiopharmaceuticals in the management of mCRPC. How should recent data inform individualized treatment? So this is the third webinar in this series. So I'm Professor Fred Sad from the University of Montreal. I chair the Department of Surgery, and I'm Director of GU Oncology. And I'm accompanied by a friend and really a star in urologic oncology, Dr. Pedro Barata, who is Associate Professor of Medicine at Case Western University, and is Director of GU Medical Oncology Research Program in Cleveland. So great to have you here with us, Pedro. So this is the third of a three-part webinar series that explores new data on radiopharmaceuticals. And the first was really around some of the data in radiopharmaceuticals. The second was really focusing on patient experiences and priorities as the disease progresses. And here we try to bring everything together in terms of using this data to try to use and make the best for our patients both translating the evidence and patient priorities so that we can optimize treatment. And we'll be basing a lot of what we say around patient cases. So we're going to, as I said, try to integrate the evidence both around the data, but also around patient priorities in the real world practice setting that all of you are involved in on a daily basis. So let's start with patient 1, and I'll hand it over to Pedro.
So let's think through this case real quick. Think of a 70-year-old man with, known with metastatic castration-resistant disease. By the way, we're going to be using PCW group 3 criteria. We're not adopting PCW group 4 just yet. But this patient was known 5 years ago with newly diagnosed metastatic disease, high PSA 145, Gleason 4+5 with several bony lesions. So we would take this as high volume disease, no visual metastasis seen. Patient was offered a strategy known as Stampede or Charted with ADT and docetaxel. He got a good response in scans. He got a beautiful, robust PSA decline to 0.1 as best PSA response. Good performance status. Patient, did well, tolerated treatment well, and continued being on ADT after completing 6 cycles of chemo. So over time, you start seeing this PSA rise, 0.5, then up to 5. And that happened while he maintained, low levels of testosterone. So he met criteria for mCRPC. He gets restaging scans. We find him to have new disease, progressive disease in the scans. So it definitely meets criteria for CRPC by scans. Also, in addition to that, he started complaining of this lower back pain, kind of controlled with NSAIDs, and yet he has a good performance status still. So you can see the imaging profile at this time. 6 bony lesions identified, continues not to have visual disease. He has molecular profile done, both germline testing along with somatic testing. No targeted alterations found, including no HR or no microsatellite instability. So at this point, the question, maybe I'll ask Fred is, how would you manage this patient, right? Coming out of ADT docetaxel a few years later, patient meets criteria for progression by symptoms, radiographic criteria, and PSA. What are your thoughts, Fred?
Right. So this is a shrinking population, right? ADT and docetaxel was really the best standard of care we had, at the time this patient presented 5-6 years ago. And, basically since 2014, we've been doing this in basically all patients with mHSPC, especially if they were high volume, where we seem to have the best. So that was ideal. And I have several of these patients that have done well. But when they progress, we do have guidance based on level 1 evidence that whether they got ADT alone or ADT plus docetaxel, the next best line of therapy is to introduce an ARPI. And in mCRPC, it would be either abiraterone or enzalutamide. And as you mentioned, if there's no molecular biomarker directed therapy necessary, we would not introduce, a PARP inhibitor in this kind of patient without HRR mutations. But as mentioned in both the NCCN guidelines and the ESMO guidelines, in a patient who hasn't had prior ARPI, radium-223 plus enzalutamide could also be a very valid option, as well as enzalutamide and abiraterone alone. And this is in both guidelines, have this now in their guidelines based on recent evidence that showed that if you add radium to enzalutamide, you actually do significantly better in terms of rPFS than enzalutamide alone. So the standard of care was offered in these patients, as opposed to the historic trials that were against placebo. Here, this is a life-prolonging, very efficacious therapy of enzalutamide alone, and we were actually able to beat that, which is really quite outstanding. The limitations were that they excluded patients with visceral mets. So bone only, bone with lymph nodes, post-chemo, post-ADT alone were all included in this trial. And more recently, this was presented and now published in Annals of Oncology. The final overall survival is also statistically significantly in favor of the combination over enzalutamide alone. So this went beyond what we had expected, because it's only basically a 450 patient study. So it's quite amazing that in such a small study, we're able to see an overall survival advantage over a very powerful standard of care arm. So it really shows that adding radium does make a significant difference if with as few as 450 patients, we were able to see both rPFS, which was the primary endpoint, and now overall survival. So, the practical considerations for radiopharmaceutical treatment, the dosing administration for radium is every 4 weeks for 6 cycles, and for lutetium, if that was the option, but it would not be appropriate in this patient, only post ADT and docetaxel, it would be every 6 weeks for 6 cycles. And, the details are here, and you can review these, but really, radium and alpha particle really requires very little attention or safety for the patient, doesn't need to avoid close contact, as you would recommend for patients on lutetium to avoid close contact because of the penetration of a beta emitter. So simplicity and both are two very life-prolonging alternatives. One limited more for bone or disease predominant, the other one for PSMA positive disease. And just a few words on bone protective agents. Now we have data from the PEACE-3 study that if you don't give a bone protective agent in the mCRPC setting, the risk of developing a fracture is very high, whether or not you got enzalutamide alone or enza in combination with radium. And when you introduce a bone protective agent, both scenarios almost eliminate the risk of a fracture that occurs over time. And these patients with mCRPC clearly need to have a bone protective agent. So let me just go on to case number 2, given the short amount of time we have. This is another 72-year-old patient who also presented with de novo mHSPC a little bit more recently. PSA elevated at 78, Gleason 8, lymph node involvement, but no bone metastatic disease. He was treated with ADT plus abiraterone and prostate radiation therapy. He had an excellent response. PSA declined to 0.1, and the treatment was well tolerated. But then over time, he had a PSA rise. He has new imaging that shows progression. He's got mild discomfort, no systemic weight loss, and ECOG is maintained. And he had a PET scan that shows that he's got PSMA positive disease, both in their lymph nodes, also in the lung and in the bones. And germline testing again here is negative across the board. So now I hand it back to Pedro. How would you manage this patient?
Great. Thank you for sharing this case, Fred, which I think is probably a very contemporaneous way to manage it, right? Offering an RPI in a metastatic hormone sensitive setting. So when patients get to CRPC, what options are out there? And I think the default plan would be chemotherapy. We know it's active. We know it works. Docetaxel has been around for a long time, and it is included in both American as well as European guidelines, as you can see there. Important always to stress out the importance of molecular characterization. Not the case here. We tested, we didn't find target alterations. We're not going to talk as much around PARP inhibition or even immunotherapy, but just keep in mind that's an option for those patients. And yet, the other aspect is, as we are considering novel imaging more and more in the advanced disease, so PSMA PET scanning, we can identify patients also for consideration of a PSMA-based radiopharmaceutical. It's available, lutetium PSMA, at least in some areas of the globe, not all of them. We could think of lutetium PSMA as an alternative, keeping in mind that there might be some restrictions to their use. And then there's also data for this aggressive variant disease, depending how you define it. We tend to use the molecular definition, TP53, RB1, P10. You get 2 of those tumor suppressor gene alterations, and you would think of a platinum taxane combo for special circumstances. So I would say chemo for the most part, lutetium PSMA in certain situations. And why is that? Well, we did see data. The trial is called PSMA-4 for patients with mCRPC who progress on a prior RPI, have not received docetaxel, and you basically compare lutetium PSMA against the second RPI or RPI switch, as we call it. At that time, crossover was incentivized or encouraged in this trial. So you do see tumor control almost double. We're talking 5.5 months all the way to 11.6 months. Yet we don't see that difference in the overall survival. As I said, many of these patients end up receiving radiopharmaceutical later time, and that's basically the data. These data did support, along with the efficacy data, along with the quality of life data that I'm showing you here on this slide. Time to worsening, quality of life measured by the validated instrument was prolonged also for patients who receive lutetium PSMA, basically around 7.5 months compared to 4.2 months. So patients reported deterioration of FACP scoring at a later time, as well as pain. Time to worsening pain was prolonged with lutetium PSMA. So when you combine these data, the totality of the data was assessed by the regulatory agency, at least in U.S. environment, and it was available and was considered to be available for use in this particular setting as well. So if you are in a world where chemotherapy is a very reasonable option, and then lutetium PSMA can be considered, let's assume for PSMA positive disease, then a logical, pragmatical question is, can we prioritize one or the other? So this Canadian study is really an effort in that direction. Getting patients, about 200 patients study, really asking the question, should I go with docetaxel first and then followed by lutetium PSMA, or should I consider lutetium PSMA followed by docetaxel? And you can see here the primary endpoint was around tumor control. We don't find a difference from a statistical perspective. Chemo did quite well, I would say, 10.7 months tumor control with docetaxel compared to 8.6 months on patients who receive lutetium PSMA. And then on the overall survival there, actually, if anything, the absolute numbers appear to favor actually the patients who start first with docetaxel. I know there's questions around who got what or how many patients got what. I'll tell you, more patients, receive lutetium if they got prior docetaxel. But the point here is 14 months for patients who start on lutetium, 18 months median overall survival for those patients who start first on docetaxel. This was actually very provocative data, but at least it puts into perspective what the two regimens that are being considered across the globe in terms of the guidelines for patients who progress on prior RPI. So with that said, let me get back to Fred to walk us through what's in the horizon, what's coming up that we'll need to talk more and consider as we think of managing these patients. Fred?
Great. Thanks, Pedro. That was great. So just to say that we haven't seen the end of research in patients with metastatic CRPC. They're unfortunately still dying of the disease. But in terms of radiopharmaceuticals, there are many new for radiopharmaceuticals, and there's a lot of effort to actually start combining radiopharmaceuticals with another mechanism of action. So we're looking forward to a lot of these studies that we'll report over the next several years. And just to show one example of an actinium-based trillium, this is a phase 1 dose escalation study where we actually see that PSA responses at the 125 dose is 83%, and overall disease response was 71%. And just a quick example, after 2 cycles, you see this patient with widespread metastatic disease, almost complete disappearance of the disease, and reduction of PSA extremely low. So really quite interesting, and this is going to go forward in the near future in phase 3. I'll ask Pedro what he thinks of this in terms of, beyond 6 cycles of lutetium, can it be continued or restarted with subsequent progression? Your thoughts on that, Pedro?
Yes, great question. So just as a comment, a one-liner on the comment, we've been considered one size fits all kind of strategy for lutetium PSMA, right? 6 fixed doses, in fact, is 4 plus 2, depending on the conventional scans. We have not optimized dosing and schedule for most of our patients. And as we use them in clinical practice, I think it's getting more and more clear that not everybody needs the 6 doses. and for many patients that receive excessive radiation and getting unnecessary toxicity. So the optimization around dosing and schedule is required. So the problem that we have is we have to generate that data to understand who needs less than that and who maybe needs more, and is that the right schedule and dosing. And so that's what this question goes. So far, we do have anecdotal reports that for some selected situations, it may be reasonable to do a rechallenge. I would discourage from recommending that for use for most cases, because we actually don't have the data to support that that approach versus other life-prolonging therapies out there. So I don't do that in clinical practice. I recognize that's an important question that maybe needs to be addressed in the near future as we try to optimize how much do every patient we see in the clinic need in regards to radiopharmaceuticals, in this case lutetium PSMA, but we can apply that thought process to other radiopharmaceuticals.
Yeah, no, I totally agree. And beyond the efficacy of maybe re-challenging, we have to really consider the safety for the kidneys, for the bone marrow, and MDS and AML that could occur. We need some more safety as well as efficacy. And the other question that came in was beyond in patients getting benefit from a bone protective agent, should we continue after they get a fracture? And I think the benefit does go beyond preventing fractures. We have more recent data from Piece 3 that those who had bone protective agent actually looked like they were delaying progression and possibly even improving survival, and that data will be published soon. Thank you both to Pedro and to everyone who attended.
This has been an activity published by Peer Voice.